Am I audible?
Yes, you are audible, Appa.
Can I start?
Sir, should we start?
हाँ शुरू करें
Okay, Appa, sir, you can start.
Dear viewers, Assalamu alaikum and good morning. I am Dr. Dilara Afroz. Welcome you all in the Bangladesh Radial Virtual Live 2020, Second International Conference on Transradial Intervention in Bangladesh, organized by Bangladesh Radial Intervention Course, BRIC. We are very delighted to greet you in this beautiful morning of 20th November 2020. So, on behalf of BRIC, I would like to take the pleasure to invite you all in this program. Thank you everyone for managing their time with us. We are sure your valuable presence will enlighten our program. Before starting our scientific session, I would like to request Professor Mir Jamal Uddin sir for giving the inaugural speech. Professor Mir Jamal Uddin sir is the Director of National Institute of Cardiovascular Disease, Dhaka, and Co-Director of Bangladesh Radial Intervention Course, BRIC, Secretary General of BSCI, and also Vice President of Bangladesh Cardiac Society. Mir Jamal sir, please.
Honorable Chief Guest, National Professor Brigadier Malik sir, the father of cardiology in Bangladesh. Professor A.K.M. Fazlur Rahman, President, Bangladesh Society of Cardiovascular Intervention. Professor Tejas Patel, who is one of the renowned radial interventionalists in Southeast Asia. Professor Sufia Rahman, Professor Emeritus and pioneer of interventional cardiologist in Bangladesh. And dear friends and fellows, a very good morning to all of you and Assalamu alaikum. I am Professor Mir Jamaluddin, Director, National Institute of Cardiovascular Diseases, is going to start Bangladesh Radial Live 2020. Though it is virtually organized by Bangladesh Radial Intervention Course. At first, I must pay tribute to the memory of our great leader, father of the nation, Hazar Boserer Shrestha Bangali, Bangabandhu Sheikh Mujibur Rahman and his family members who were killed brutally in 15th August 1975. Thank you all to be here virtually in the difficult period of COVID era. For the last 1 year, the whole world is passing a very critical time due to COVID-19 infection has vastly affected the economy, social life, education, and health sector. In Bangladesh, our doctors, nurses, and other healthcare providers have dedicated their lives for protecting COVID-19. More than 100 doctors in Bangladesh have already sacrificed their lives due to COVID infection, including one of the renowned interventional cardiologists, Professor Hossain Chowdhury, who is the one of the renowned interventional cardiologists, and another 2 cardiologists also expired due to this COVID infection. And statistically, what showed, if you see worldwide in the globe, it is in favor of transradial intervention, gradually converting from transfemoral approach. Initially, the transfemoral approach was started for coronary intervention all over the world, and gradually it has been shifted from transfemoral to transradial approach. And if you see that the statistics in UK, it is almost 90% procedures are done, coronary procedures are done by the transradial approach. And in America or USA, it is approximately 70% procedure by transradial intervention. And in Europe, it is approximately 60 to 70%. And in our Bangladesh, we are also going forward, and our statistics also shows that approximately 30 to 40% interventionalists are doing this procedure transradially. We all of us know the transradial approach is more effective, and transradial approach there is less complication. And you know that from ESC, European Society of Cardiology, in 2019, they have declared that class 1 indication is transradial approach, particularly in primary PCI. And they have also shown that there is also mortality benefit of transradial approach in case of primary PCI. In other cases, there is significantly low complications in transradial approach rather than transfemoral approach. And our country or our young interventionalists, those who are budding, they are almost all trying to cope up with the procedure. And for them, we have arranged this Bangladesh Radial Intervention course through which we can do the live program. We have done last year first international radial live, and where we also shown the live cases, and in this year we are also going to launch 4 live cases, 2 from National Institute of Cardiovascular Diseases, 1 by Professor Malik from National Heart Foundation and Research Institute, 1 from Ibrahim Cardiac Center by Professor Maksumul Haq. And by this way, we can try to introduce the procedure to the younger interventional cardiologist to make it confident to them, and to make it easy to them, and to save our young cardiologists for reducing radiation, for reducing the thinking for complications. And most of the centers of Dhaka and Bangladesh, they are doing radial procedures, and the persons who are not yet doing the procedure, they are also transforming from femoral to radial.
I think today's seminar will give us a new dimension, another new dimension to do this work. Thank you all. Thank you very much.
Thank you, sir, for your valuable speech. Now, I would like to request our special guest from Professor Tejas Patel to give his speech. Professor Dr. Tejas, Professor
Apart,
Dr.
Tejas Patel sir hasn't joined us yet.
Okay. Uh, Professor, sir, sir is
Brigadier,
here.
Brigadier sir,
Okay. Brigadier,
Brigadier
sir.
sir.
We are honored to have within ourselves as Chief Guest National Professor Brigadier General Abdul Malik sir. National Professor Brigadier General Abdul Malik sir is a father of the cardiologist, Honorary Secretary General, National Heart Foundation, Bangladesh, Founder President Bangladesh Cardiac Society. I would like to request sir to give the speech. Thank you. Thank you, sir. Professor, National Professor Brigadier General Abdul Malik sir.
Bismillahirrahmanirrahim. Honorable President of the session, respected faculties from home and abroad, participants, Assalamu alaikum. I am very happy to be here in this inaugural session and congratulate and again thanks the organizer for arranging this important continuing medical education session. Now, Professor Mir Jamaluddin has elaborately told the development of intervention from femoral to radial. Radial has got lot of advantage, and initially it was started in femoral, then gradually they are shifting to Bangladesh to radial intervention. Now we must remember that theoretical knowledge is very important, but practical is very important. So these types of interventional international conference will give chance to our younger generation to learn from each other. And I again thank all of you for taking Bangladesh gradually in the field, in the international level. All of you know we got independence in 1971. At that time, Bangladesh had nothing. But today, with the grace of Allah and all of you have worked very hard. So we have taken cardiology in the international level in every way.
Malik sir, এটা দাও।
Intervention,
Last এটা দাও।
echocardiography and everything. So I again congratulate all of you, and I will request all of you to make more manpower, because today the manpower which is available in Bangladesh is not enough to meet the demands of our people. We have got large population, and even today the facilities are confined to Dhaka and few big cities, but we will have to spread this facility. So please make more people, and it is not the doctors alone, whole technologies, other technologies should be developed. So please make arrangements, and I always pray and thank all of you. Take lead. Nobody is here forever. We come and go, but we should leave people behind us so that our people get facilities. So please, thank you very much for inviting me, and please remember that we should try to be honest, we should try to learn and give our service to our people with our utmost good intention and keep our mind very clean. So thank you very much. I am sure this conference will be very useful for younger generation. Please try to learn. And I again thank the international faculties who will participate and help our people to develop this facility. Thank you very much. We wish you success. Allah bless you. Thank you very much. Thank you very much.
Thank you, sir, for your valuable space. We are very glad because with present us Professor Sufia Rahman and also our special guest Professor Mansoor Salam from Cairo, Egypt, and Nasser Norlis from Mexico. Welcome to all. Now we are moved to our next session. Our scientific session. This is now we'll move to our demonstrated live session from NICVD, National Institute of Cardiovascular Disease, Dhaka, from Bangladesh. Thank you all with being us.
Thank you.
Thank you all. I'm the Professor Amal Kumar Choudhury, Professor of Cardiology at NICVD and Secretary Academic Council. I am the moderator, and with me, the co-moderator is Associate Professor Ashok Kumar Dutta from National Heart Foundation. Now we are going to start the first session, that is live case 1 from National Institute of Cardiovascular Disease. This is the Attraction Institute of our country in the government level, and we have right now functioning 5 cath lab. Right now the total number is 7. Among them, 5 is functional. In this session, live case 1, the chairperson is very, very renowned and nationally and internationally highly reputed cardiologist in our country. Chairperson among them, the 3 chairpersons, first Professor Emeritus, Dr. Sufia Rahman. She is the mother of interventional cardiology. We acknowledge her as a mother of interventional cardiology in Bangladesh. And then Professor Fazila-Tun-Nesa Malik. She is also the Professor and Chief of Interventional Cardiologist in the National Heart Foundation and Research Institute, Dhaka. In this year, Fazila Malik is guided the team which won the EBC European Diffraction Club first prize among the case competition, which is enlightened us, the Bangladesh, as well as her team, as well as and Professor Afzalur Rahman. None to say about him. He is also the President of Chairperson of BRIC, Bangladesh Interventional Therapeutics, and also renowned cardiologist, ex-director of NICVD, and also the ex-president of BHA. And we have also a galaxy of panelists, which is interventional cardiologists. Among them, Professor Khandaker Shaheed is the Professor of Cardiology at NICVD, and Professor Mashhud Chowdhury from Ibrahim Cardiac Center. He is also a renowned interventionist. And Professor Mohammed Shahabuddin Talukder from Imagine Hospital in the Apollo Hospital, and Associate Professor Pradip Karmakar from NICVD, and Dr. Professor Dhiman Banik from National Art Foundation, and Associate Professor Abu Salim from Bangladesh Sheikh Mujib Medical University. So we are not delaying to start our case. Sir, can you hear me, sir?
Yes. Are you hearing me?
Yes, sir. Sir.
Okay, this is our first case.
So, I like to request Ashok Dutta to continue the session so that our fellows, our mid-level and senior people can understand the case and how handle the our president, coach director of BRIC, done by the Professor Mirza. So we like to know from him what he is doing. Thank you, Ashok.
Professor Amal.
Yes, sir.
This is a 37 years old male having old MI inferior with clinically post-MI angina, and 1 month back angiogram was done, and angiogram showed in the right coronary artery there is disease in the mid right coronary artery, and on the left system, if you go for left system, you show the left system, there is narrowing in the ostium of the left main. Probably it may be significant, and so we shall have to see it. And in the mid LAD without inter MI, this type of lesion, meaning that it is a situ, and so we are going to do first situ, and then we shall evaluate the ostial left main and do accordingly if necessary. And my for your kind information that you can see, this puncture is from distal radial to be from 2017 December. We have started distal radial approach, and mostly you can tell that I do mostly by distal radial approach. Check.
Thank you, Mirjamal sir. So you have gone through the distal radial. What is the size of the catheter? Is it 6 or 7?
It is 6.
6 French EBU. EBU.
Extra backup. We can also do 7 French by distal radial approach, where we use glide sheath cylinder.
But in this case, you have used the normal sheath, yeah?
Yes.
Yes. What about the lesion on the right side? That means RCA there is some dissected. Yeah.
Yes, dissected, and that was seen during acute MI inferior, and so they have not done anything at that moment. And now we shall do the left system, and then we shall also address. We shall see the right system, and if necessary, we shall do all the right.
So I'll request our.
Now I am starting.
Yes, sir. What is this wire? This is the run-through floppy.
Run-through floppy. Filter FC. It is filter FC, and with the micro catheter fine cross, we are going forward. This is my fine cross is coming.
So, any opinion from our panelist, Professor Shaheed Hossain, Mashhud Chowdhury?
Sir, what is your plan, sir? After wiring and ballooning, what is your plan? You will do the pre-IVAX, then stand sizing and go for the standing?
As because the IVAS is with, in our hospital, and so because, we shall do the IVAS, and then this wire is crossing, and we shall then do the stenting after IVAS.
IVAS to the mid LED lesion or IVAS to the
Mid LED lesion for sizing as well as for detecting the length of the
yes, sir.
stent.
Sir,
And then
opinion
I
from
shall
the
see the
yes.
LM ostium.
So do you want to, sir, do you want to do the IVAS after pre-dilatation or before pre-dilatation? Is it possible to negotiate the IVAS catheter? I think
Yes, it is possible, probably. If possible, then I shall I shall see before the pre-dilatation.
yes,
You see, my the tip of the my microcatheter is beyond the
lesion.
wire, meaning that I am pulling back the C2 wire, and then I am doing with another
Run through or floppy wire.
fluffy wire. Run through fluffy.
So I would like to request our expert panel. Do you have got any other other than this way? Someone want to do the procedure in a different way? The plan from Mir Jamal sir is to do the stenting to the mid LED, and before stenting, he like to do the IVAS for vessel sizing and to see the nature of the lesion. And after this, he will do the pre-dilatation, then stenting, and afterwards, before finishing the procedure, he like to see the FFR to the ostium. Yeah,
ostium. We shall see the IVAS of the
ostium. Yes.
Ostium.
Are you planning for a provisional stenting of the LED or LED and diagonal both?
And this diagonal, you see
small,
the size of the diagonal is not very much, not more than 2 milli, and that is why I want to do the provisional stenting.
Yes, that is good.
There is this very tight bifurcated lesion before pre-dilating the LED and diagonal. It is very difficult, sir, to comment about the diagonal size.
That is also correct, and after checking the IVAS, we can tell.
This is the run through or Sion blue, sir? What is your default workhorse wires among soft wires?
Mostly Sion blue and
yes.
also run through.
Yes.
Give me the IVAS.
Sir, as far as I know, you also use Renato. Renato is also, sir, good?
Yes, Renato is also good.
Also good.
With me, my co-worker is Associate Professor Dr. Mumen, Professor Sabina Hashem, and Dr. Mijan, my registrar, and Dr. Sakib Shahriar, our registrar. They are with me, and our chief technologist. By this time, already Associate Professor Kumar Karmakar has joined, and with me, our team members, other team members, Dr. Technologist, Chief Technologist Liton, and all other staff nurse and other technologists.
So I'd like to request our chairperson, Professor Sufia Rahman Madam and Professor Fazila Madam, for their valuable comment on this patient, on this PCI.
It is not crossing, so I do the first dilatation and then I shall see. But this time I want to see the ostium.
Yes.
Because your angiographic finding, you have commented that there is a plaque in the ostium of the left bed.
Yes, yes.
So it will be very valuable for this setting. If it does not pass the situation, cytodilation in mediality, in this setting, you can assess the plaque burden in the ostium and mid left bed.
Yes, IVAS pullback is going on.
And can we see the IVAS? Okay, yes.
Yes, yes.
As it is guide is extra backup, so I am pulling out the guide from the ostium for visualization.
Yes, sir.
Okay.
So,
So what is your IVUS
wait,
machine? Is it a Volcano or is it a Boston Scientific?
Boston Scientific, madam.
Right.
Opticross, probably. From Boston Scientific.
IVUS, please. Can you focus on IVUS, please?
Show the IVUS.
Madam, can you hear me?
Yes, I can. Thank you. I can hear you very clearly.
Madam, is there any other option or other ways to handle this lesson, like mediality, like if you are there, what you did?
Professor Mir Jamal is a very experienced operator, and his strategy is absolutely fine, and we need to see how the things go and learn from him. So I'm totally in agreement with what he's doing.
And show the ostium, IVUS of the ostium.
Madam, can we keep then keep see the size of the diagonal vessel? Then need to keep the wire in the diagonal vessel. Madam.
Yes, well, actually, you see, Professor Mir Jamal has already commented that he feels that the diagonal is not an issue. And he thinks that even not impact his outcome. So he has decided to keep the procedure simple, and he wants to not be bothered with the diagonal right now.
Exactly, ma'am. Lead pen is 4.5 millimeters as per IVUS. So LED will be 3.5 or maybe even 4.
Right, please. No problem. Right, please. Check.
So this is one of the drawback of the radial procedure. With each breathing, if the patient take deep breathing, then sometimes catheter moves and maybe disengaged. So this is a drawback for the radial.
Actually, I'm not a great radialist, but that's why I don't disengage my catheter while I'm doing a radial procedure, you know. It's better to keep it there as coaxial as possible.
Yes.
Other way, madam, what I used to do, I put a wire to the second wire to the LCX. That gives a big support.
That's a very good option. To keep your catheter well supported, then putting a wire in the L6 is a very good idea. And actually, you see, once your catheter is coaxial and it's giving you great support, it doesn't really matter whether you've gone through the radial or the femoral. The support is only an issue in case of radial. It doesn't give us as great support as
femoral.
Madam, should we consider the 7 fans instead of 6 fans guiding catheter in presence of left main ostial lesion?
Well, you see, with the 6 French guide catheter, you can do all procedures. Like even DK crush, you can do with 6 French. So I think 6 French is fine. The only issue is that we can sometimes reuse things, but when you are using a 6 French guide catheter, all your things have to be new. The wire, the balloons, the guide catheter, everything has to be new. And every time you recross, the balloons have to be new. So the cost goes up, but yes, 6 French will accommodate a decay crash.
Madam, accommodation is not an issue. There is a chance of pressure damping to the...
No, I mean, if there's ostial left vein and you deep engage your catheter, then there'll be pressure damping. Otherwise, I think pressure damping. Also, what do you think? Do you think pressure damping should be an issue with 6 French? I don't think so, right? With a larger catheter, you mean?
Yes,
no, I don't think it should be an issue.
In that case, we can use the PP, means side hole catheter for the left.
With side hole catheter, false sense of confidence. There is actually a problem, you don't get it.
Yeah, Dr. Momen. Can you show us the NGO?
Have you pre-dilated, sir?
And just now I am going to pedalate.
We like to see the angiographic monitor, not
On the angio monitor, please. Yes.
difficult.
Give me the balloon. 2 into 20.
Professor Khandaker Shaheed Hossain is there. Khandaker Shaheed Hossain. Can you hear me, Mashhud Jia?
Yes, yes.
Can we put for support, because there is a we saw there is a problem to of the catheter. Can we in this time can we put another wire in the LCS or the diagonal one, because we may want to enter.
No, this time catheter dislodgement is just as Jamal sir has pulled it to visualize the property of ostium. That's why it is dislodged. Otherwise, it won't be, I think.
Yes. Check.
What is the balloon, sir? 2 into 212.
212. Yes. Very correct. Go up.
Sir, if we pass the two balloon,
go up.
Already crossed.
Small balloon. So tight. This 2 is not crossing. 1.5.
Are you sure about the distal tip of your wire?
Yes. Distal.
That is friendly loop is there.
And loop, if there is loop, I like it.
That's good. That's good.
I am very much fond of this loop distally within the lumen. Another balloon. Check. No.
So flow is established. So diagonal is not so small. Diagonal, that is a good size diagonal is there.
No.
At least you need to wire the diagonal. Yeah.
We can wire the diagonal. We can, as because even then it is not more than 2. You see, my guide is 6, that is 2, and the diagonal is less than guide.
Yes,
distal one is 2, but middle one, that is inside the lesion, that is not more than 1.5 or maybe 1. Even then, after dilatation, I shall see the diameter of the vessel, and if necessary, I shall give another wire to the diagonal, and I shall do jailed balloon technique in that case.
Yes.
Show me the balloon. Give me the balloon.
What is your now? What is your strategy, sir? Mediality and left main ostium.
Left main ostium, is it significant? What does it show? It is not significant. Ostium.
How much plaque is there in the left main ostium?
How much plaque?
Less there.
Osteal plaque burden?
Generally, by definition, 50% or above, you need to treat it.
Now, actually, after so much manipulation, left main ostium become more narrow because of spasm, I think. After
but
90,
the left main ostium looks a bit significant, doesn't it? So, did we evaluate it properly with the Iverson FFR? I mean, it does look pretty serious.
So this is the same balloon or N balloon of same size?
No, this is the second balloon.
Yes.
20.
Downsizing, sir, 1.5.
1.
No, 1.5.
That was entered. That was previous one entered, but I did not find due to inflated balloon was inflated with water, and that is why we have not seen early. And
yes.
Well, balloon is jumping proximally and distally. Go up. Reflect. Take a cine.
All the chairperson panelists, can we use in this critical case any NC balloon directly? Because it is very fibrotic. We see. Any opinion?
Madam, any NC balloon actually when you see the IVAS catheter is not passing, so NC balloon is more bulky. In that case, NC balloon 2 millimeter available. If it is newer, sometimes that may cross. Otherwise, compliant balloon is better because there is more possibility to cross the lesion. Madam, what, for pre-dilatation, madam, pre-dilatation, do you always follow 0.75:1 pre-dilatation or 1:1 pre-dilatation?
Well, 1:1 is not very common, is it? Only in certain situations would we go for 1:1. Otherwise, we tend to undersize our balloon a bit.
Yes.
That's our common practice. But in certain situations where you feel that you really want to do a very proper job of the pre-dilatation, the lesion is extremely fibrotic or slightly calcified, then you go for a 1:1. But usually it's a bit smaller in size. That's my practice. What is your practice, Ashok?
I follow the same rule you. I actually, most of the knowledge I have gained regarding the size, especially I have learned a lot from your IBAS, though I don't do the IBAS frequently, but sizing, during sizing, I always remember the IBAS that you usually do in your cath lab.
I think about the comment about the Ashok, the pre-dilatation size, what I follow that if there is any indentation in the semi-compliant balloon, we try to see that there is any calcium speak or calcium is there, not to dilate after standing. So at that time we use 1:1 balloon or full dilate.
Actually, Amal, I want to just differ from your opinion. If there is suppose two balloon is not well inflated, there is a dog bone effect like this, then bigger balloon there is increased chance of rupture of the vessel. In that case, 2 or 2.5 non-compliant balloon.
Yes, I'm doing NC balloon.
Yes, definitively NC balloon and undersized balloon at high pressure. 1:1 balloon above 18 atmosphere, there is every possibility of big dissection and rupturing of the vessel.
After pre-dilatation, now I want to see the length and dia of the vessel for stenting, and so my IBAS catheter is pulling back. Pull back. Yes. Started.
So distally it is 3 millimeter vessel.
Yes.
And proximally 3.5.
Approximately 3.5.
Lot of plaque burden is there.
Distal area is negative remodeling.
There is some calcification at from 6 to 12 o'clock position.
IBAS catheter is pulling back from distal to the lesion.
So a lot of calcification from
yes.
9 to 12 position.
But you see calcification is a thin rim.
Yes,
thin rim of calcification and not more than 90
So this is diagonal. This one is diagonal that I just showed.
At the level of the yes.
So if that was diagonal, then ostium of the diagonal is not so bad.
proximal one, ostium is not so bad, but second one, that is further narrower, that carries ostial lesion.
This may be the learning zone.
Yes, they will tell, IBAS will tell.
Can we see the angiography?
Angiography once again?
No, that is the pull back of the IVAS catheter.
Yes.
Side by side with the IVAS.
Okay.
Yeah, side by side.
What about the hemodynamic status? As Ashok has mentioned that there is a significant stenosis of left main after re-engagement.
So this is 6 sprains without PP, sir?
6 sprains. Dr. Kajal, can you show us the hemodynamic monitoring? What is the patient status?
Around 100, around 100, 90 to 100 systolic. And guide is a bit deep throat now.
So what is your distal landing zone diameter?
Yes, that is why we are seeing IVAS will tell us. We are taking another cine.
So as per IVAS, what should be the length of your
Yes.
Length of the stent is very important for these cases. There is a distal plot is also extend into downward, and proximal plot is also extend up to bifurcation of the L6. So
what is the plan? You want to touch the distal plug or just normal area in proximal to the distal plug?
Distal plug, how much percentage? Distal plug?
So just after bend from the second diagonal,
yes,
there is LD zone between the second and third diagonal.
What is the plug burden? If it is less than 50%, you can leave it.
Plug burden distally? Distal 83%. That is this one, second one.
So at the level
83.
of second diagonal, it is 83%.
If the plug burden is really 83% after the distal D1, you should cover it. You should cover it.
In that case, you may need 48 millimeter stent, but there is an issue. There is an issue of passing the stent through this bend and calcium. So it is better.
One and another thing is also whether 48 also cover or not.
Not, yes. So better to
take two.
Yes. So first, it is better to do the stenting to our initial target lesion. Then after nitro, distal vessel may change its diameter.
Yes, you are very correct. This can be done.
Why not give nitro now and see the distal one as well? Because putting a stent where you are thinking there is some calcification is there maybe, and with the very thin calcification we have seen. And I think, if you want to plan, one would see the vessel after giving nitrate and see what is the situation.
Yes,
if needed, you can check the distal lesion as well, because after putting a stent in the bend with maybe it will be 20 or 22 millimeter length you will need in 3 size, but then if you need a one in distal, that time it will be very difficult to negotiate another stent. So if there is a calcification on the way. So I think for me, I would give a nitrate and see the whole thing again.
Yes, madam. We are giving nitrate, and just after giving nitrate, we shall see. And distal lesion after the last diagonal is 41% plaque burden. Is it?
Okay, we can leave it.
Yes, 41%.
Yes.
So we can leave it.
Yes.
Then we can cover the mid between two diagonals distally.
Yeah.
What is the dia, sir?
Dia 3.
Dia is 3, I think. Yeah.
Yes, sir. The distal the 3 and proximal 3.5.
Considering the proximal landing
What
zone and
length
distal
you
landing
what
zone,
length you are taking?
Yes, madam.
What length stent you are taking? From the IVAS, it was not clear in my screen. About seeing or maybe 22 to 25 maximum.
Length they have shown 36.
Oh.
Yes.
36.
IVAS, can you show the proximal landing zone? IVAS proximal landing zone.
You see now, this is the scenario after giving nitro, and distal one 41% plaque burden, so we can easily leave it, and we can keep distally in between two diagonals. Both the diagonals are good caliber, but second diagonal in the mid part, the diagonal is that is ostium is diseased.
Yes.
Ostium is diseased. So if we want to,
this diagonal, the diagonal what we are discussing, this diagonal have another lecture, the 100% occlusion in the distal part. Only branches we are seeing. So I think it does not need to address anymore.
I am not seeing any total occlusion diagonals.
Sir, the distal part, sir, this after branch, there is a shadow of diagonal. There is a shadow.
Not there is no total occlusion of any diagonals. You see,
it may be difficult to wire, but not total occlusion.
Yes, it may be difficult to wiring due to two reasons. One is its origin. Second one is criticalness. Third one is angulation. Fourth one is there is dissection by the pre-dilatation balloon. So it will be difficult to engage to cross that diagonal with a wire. And so I want to introduce now.
We have to treat the parent vessel at least.
Yes, we have to treat the parent vessel, and these small vessels, I think they will persist.
Sir, after that, I think if it is totally occluded, then you can open the, can you use in this place, you are very familiar to the gel balloon technique to protect the side fans. Can you use in this technique, sir? Gel balloon in a D1, because it is not more than 10 millimeter of the osteal disease. So you can just to protect the osteum, can you use the 1.5 balloon or gel to protect?
Yes, that I can do, but it will make the clumsy procedure. Procedure will be clumsy. Even then, if the house wants, then I can try to engage another wire into the diagonal, and I can keep one balloon, making it more positive for surviving.
I like to request. I like to.
House tells what is your decision.
If moderator allow me, then I can add a point.
Yes, Dr. Ajam.
Professor Azam.
Thank you very much. Actually, pre-starting strategy, whether I should go for double stent strategy or elective double stent strategy or single stent strategy. And here clearly the decision is that single stent strategy or provisional stent strategy. In that particular situation, whether I should intervene the side branch, I should intervene or not. If the more than 10% area is supplied,
yes,
significant, then I should three decisions should be taken, either the wiring or not wiring. In this particular situation, this decision was already taken for single stent strategy.
What is the size of the stent?
Side branch is significantly
3 into 38.
3 into 30. Dr. Ashok.
Yes, yes.
Dr. Ashok, we have very renowned two dimensional cardiologists, Mansoor from one of the Mexico. Can we get from request them to comment about this? Mexico and Egypt.
So,
cannot see
Dr. Mansoor.
Show me another
yeah, Dr. Mansoor and Dr. Nasser, both of you are welcome. So, we like to listen some comment from you regarding this procedure. Dr. Nasser and Dr. Mansoor, please.
Yes, sir,
Thank
it's
you so
okay.
much for the opportunity to share some experience about the radial approach in this case. It's a very honor for me. From
You can pull a little bit proximally.
Louder, please.
You can pull a little bit proximally and then see it on the portal view.
Listening?
Yes, we can hear you.
Thank you so much, Said. I think it is a particular case was the preparation of the vessel is more important than the procedure. You can see that in this case particular, the use of the eyeballs is more important. I think that because you can perform a good modification of this tissue here. You can put a good expansion of the stents you selected. I agree with the operators that the 3 and 3.5 are a good size of the stents for this case.
Yes.
In this particular case, I think the diagonals are not compromised, inclusive with the dissection in this segment. Maybe a guide practice for try to preserve all the vessels, other branches in this particular case, I think. Thank you.
Thank you. Thank you very much.
I think Afzal sir is with us. Can we request Afzal sir to...
Yes, sir. Afzal sir is there.
Professor Afzalur Rahman.
Yes, please.
Sir, what is the type of stent? Can you say which type of stent is good for this lesion?
I think so. Any new generation stent is good for that. Either you can choose the Abbott one, or you can choose the Boston one, or you can the Medtronic one. And also you have an Terimo is also not bad in this case. But I think so. This the stent which give the good side band protection. Actually, the most of the stent, though it is claimed that Medtronic is claiming that their side branch protection is better, but synergy is not also bad. So I think so any kind of stent can be a choice in this case. And regarding the strategy, I think so I am agree with you. Single stent strategies, but I would like to put one wire, at least one wire in the diagonal. So the wire is not because the side branch is not small; it is reasonably good size. And so I would like to, and the ostium is also digit. So I would like to put one more wire into the diagonal. Yes, you can do the balloon technique, but I think so. I would pack one wire into the diagonal.
3.515.
Thank you, sir. Second option was if we keep a wire, we can open a ostium by a small, very small balloon. It is also another option.
Yes,
to open that start early, because it is ostium lesion is less than 5 within 5 millimeter.
I think so. I agree with you.
Yes. So this is the.
With the permission of the moderator, Professor Amal Choudhury, can I say with the operator something?
Yeah, thank you. Yeah, of course. I'm not seeing you. Okay.
Welcome, Professor Mahmoud Rashid.
Sir, Mirjama sir.
Thank you. I want from you.
Particularly in this case, sir, ostium is covered, sir. LED ostium.
No,
I think
LED ostium, there is no significant plaque. We have seen the ostium, there is only 23% plaque. And I do not want to cover the 23% plaque.
Oh, okay, sir. You decided to
Yes.
not cover the ostium of the LED.
Yes,
Okay, okay.
and our IBAS told it is 36 millimeter, and we have given 38 millimeter.
So a bit 36 was perfect.
And that was
what is
perfect.
what is the post dilating balloon, sir?
3.5 into 12.
So your distance was
balloon. Yes.
Distance was 3. Now you are post dilating with 0.5 millimeter upsize balloon.
Yes, yes. And then we shall show once again by IVAS.
What is your optimal pressure for this patient here?
Pressure, how much?
No, pressure means post dilatation up to 12 or up to 16 or up to 18. 16. I think proximal.
And in the proximal part, I shall give further
18
more.
may be
Yes.
The better option.
You see, I am in the just ostium, meaning the just starting of the stand. You want to see bush?
Stand boost, yeah.
Can I do attention Dr. Ashok Dutta?
Yes, sir.
Do you think is it matter to optimize post dilation balloon, NC balloon, 12, 14, 16, 18, 20?
Yes, definitively. Post dilatation balloon, if it is the same size with the stent, I usually do at least 18 to 24.
Yes.
If it is 0.5 millimeter upsizing, then 12 to 18. And depending on the nature of the post dilatation, sometimes upsize balloon, sometimes we go up to 20. And sometimes it happens in the same pressure. If you post dilate 2 or 3 times in the same place, that gives a better apposition with the vessel wall. Same pressure, suppose 12 millimeter, first time appose well, but second or third time post dilate can give a better apposition.
Yes, I got your point. If you use NC balloon same size, suppose you go for high pressure at least 18 to 20 years, because if you go more high pressure, these NC balloon at as much as possible expand 6%. If
yes.
And if you go more higher pressure, 20, 24, 26,
yes,
you only expand only 0.6%.
Yes.
So if you go for upsize balloon, one size upsize balloon, you can go at least 18.
Yes.
Two size, then you at least 12 to 14, or just a bit higher than normal.
Mirjam sir.
Yes.
I think your proximal part of the stent is little bit still under regarding to the distal part in comparison. In bush also showing that.
Yes, you are very correct. After that scene, we have also given the high pressure balloon with 18 atmosphere.
Okay.
I think you want to do the IVAS now for
yes.
This is the best option, I think.
Yes. I am going with IVAS.
Because we have IVAS, so
what is the? Can I ask one thing? What is the strategy when you are post dilating it? The size of the balloon length. You are taking to dilate it part by part, or you will dilate the with the long balloon and the proximal part.
Madam, I like to listen your opinion. What is your experience? Is it short balloon is better, or 12 or 16 millimeter NC balloon is better? I usually, most of the time, I use shorter balloon, 8 or 10 millimeter NC balloon.
Yeah, you're right, but shorter balloon for short lesions. But if you see, this is a metal cage, so you're dilating in different. Say you have to cover 18 millimeter, and you have taken 12 millimeter balloon, so you have to dilate twice, right? But if you have 18 millimeter, if you take 18 millimeter balloon, then you have to dilate once, because you are dilating a metal jacket inside a vessel. So if you dilate twice, there is a chance of having dilatation equal from the proximal to the part you are trying to dilate. So I usually what I do, I take the length which covers the post dilating part I have to dilate. I take that size balloon. Because
Madam.
if the metal is such a thing, inside the body, if you dilate some part, it will dilate, and the second dilatation will cover the proximal part as well as the distal part, and that might not be the same dilatation as you are expecting.
Yes.
Madam, in case of when the vessel size is not uniform, that distal part diameter is less than proximal part. In that case, I think that small balloon will be more
That is true. If there is a size difference between the proximal and distal, here there is no size difference. It's a 3.5 or 3.2, and the distal was 3.
Madam,
here is dilating with a small balloon. You asked my strategy, so I said that that's what I do. But if the size from 0.5 to 1, definitely we have to
finish. বললে ভালো হয় যে মানে প্রফেসর মালিকের সাথে শুরু করতে বলা
if I deploy 38 scale, at that time post-planation strategy that what will be the length of this balloon, or if 1.5 upsize or same size, what will be the length in long stem? Because if we take a very short balloon, it will inflate it. If it is 48, how much time? With 10 balloon, it is 4 times. This time it will overlap by overlap. If we dilate by overlapping every place, it will take to the 48 to 4, 5 or 6 times it need to dilate. But at that time I use little longer NCBL, little longer. Up to 15.
Can you see the
What is the plan now after post-dilatation? Are you going to use the IVAS or your stand boost? You are going to show both?
Amal sir, can I say something?
Yeah, of course.
Regarding the pressure, the post-dilatation pressure, there are some recommendation because it is not always true. You can go to the 24 or 24.
You see the IVAS pullback.
It depends upon the vessel is the positive remodeling or negative remodeling or the plaque attenuation. Because in our country, I have get that 20% of our vessel is negative remodeling. So in case of negative remodeling and the positive remodeling and the plaque attenuation, you should be in the conservative. You should not go through the 24, then it will provoke the rupture. Another thing, the proximal landing zone. Landing zone is important. If the landing zone is in the 50% plaque burden or maybe the normal plaque, if you don't have the any normal vessel, so we can place the stand in the less than 50% plaque burden. If you put the landing zone in the 50% plaque burden, you will be conservative in the post dilatation. If you in the normal zone, then you can go to upper. So there are some guidelines how much you can go for post dilatation.
Thank you, Pradip, for a nice comment about considering the plaque burden and landing zone, and also remodeling, negative and positive remodeling. If it is positive remodeling, we can use the more pressure, more upsize balloon. If it is negative remodeling, this is the downside and conservative pressure.
In Bangladesh and India, there is a 20% diabetic patient. They are negative remodeling vessel.
Okay.
Yes. Okay. Thank you.
And you see the.
Could you consider the recrossing the diagnosis? Second diagnosis.
So someone can just explain how the IVAS is looking. Do you think that it needs further post dilatation, or is it okay?
Yes. You see the IVAS.
Distal age. IVAS, can you do the distal age? I want to see the age dissection.
Yes.
এটা আবার মৌল হতে পারে, দুইটা হাইড্রোজেন একসাথে হলে একটা মৌল হয়ে যাবে। H2
Fazila madam,
are you seeing
your opinion regarding that IVAS findings?
And it is minded the post dilatation IVAS findings. So
yes,
need to further post-dilatation or it's okay?
First, show me the distal age.
Pradip, there is a small age detection in the distal age. You see.
Yes, for this reason I'm asking, because every age dissection is not important. If the age dissection is more than 60 degree, it is more than 3 meter length, and dissection stand into the media, only then it should be clear. Neither eye is left alone.
Is there any dissection? I don't find any dissection.
I don't also find. IVAS is not also fine. IVAS tells us there is no dissection, and my eyes tells us there is no dissection.
Can you go further? Still stand is there.
If you notice this dissection, single operator, we should appreciate. But we are the multiple eyes, we don't find any
no dissection.
No dissection. Yes, thank you.
Induction.
Can I finish?
To keep it in mind, it is. It could be, but significantly we can't address it right now.
So actually, this is excellent result, sir.
Yes.
I must
Congratulations, sir.
Thank you all.
Very good.
And
Like it, thank you very much.
as you said previously, sideburns should not to intervene. It doesn't mean we should not intervene. Actually, this flow is already same as before. So right now we need not to recross the wire to open up the mouth of the diagonal. So we can keep it as it is. So we believe we can live here and follow up the patient for the further event or not.
Thank you,
And
Dr.
what about the
Thank you, Dr. Rajam. What about the last thing that is very much important to our chairpersons and to our expert panel regarding ostial left main? What is your decision? Do you want to keep it as it is, or do you want to do further anything? Regarding LED, it's okay. Regarding diagonal, it's flowing timid too, so no need to intervene it. What about the opinion regarding ostium of the left main, please?
Ibas, can you show with the ostial left main?
Yes. Show it.
Ashok, it is actually sole discretion for operator, but we can take initial information from our chairperson, whether we go for intervention or not.
Yes.
As operator decides,
madam.
primarily he is not interested to address the ostium of the left main. So we can add some extent, some point in favor of if someone consider whether we should intervene or not.
Yes.
And any of our chairperson can make
Dr. Professor Afzalur Afzal sir is there. Dr. Ajam said, Professor Ajam said that the comment, he is expecting the comment from chairperson. Afzal sir?
What is the MLD? MLD 6. MLD 6. Is the MLD 6?
Yes. Sir.
What is the MLD of the ostium of the left main? What is the MLD of the
ostium? Around 31% plug button, but MLD is not.
What is the MLD of the ostium of the left main? That I have to know first.
Just moderator হিসেবে বললা এইটুকু বলতে পারো
it is almost disease free, and you see this is the ostium. Mild disease, very mild disease. Even then we can think if it would be more, and in the other hand there is no pressure drop, and so we can also indirectly understand that this may not be critical, and to me it is not critical, so I like to avoid it doing another stent in the ostium of the left main, and that is my decision.
I think I agree with Professor Mir Jamal. I mean, looking at the IVAS, it looks pretty reassuring. The left main is a very large lumen vessel, and the disease we find is very minimal. And as he has already highlighted, there is no pressure damping. So I think it will be counterproductive to put a stent in this large left main with minimal disease and no pressure damping.
Yes.
I do agree, and actually honor Professor Jamal's decision regarding left main stenting. There's no need for this. Thank you.
There is critical lesion on the RCA. What is
Yes, RC should be done
in the next setting or in the same setting?
next setting,
Yes,
not this setting, as because at 12:30 another case we have to
yes.
do,
Thank you.
and so we shall do it next.
Thank
Thank you all the
Can we see the
chairpersons.
last scene?
Thank you. Well done. Well
Last
demonstrated
scene,
and well done.
Thank you,
Last
sir.
last scene, angiographic scene. Last angiographic scene. We like to see last angiographic scene.
This
After
one is
90. What?
yes.
Mijan, can you see the last scene?
It is in the screen.
Screen, please. Yes.
Sir, screen, please.
After removing the wire, do you want to take another view?
Any caudal view? Any caudal view, please?
A caudal, RAO caudal or caudal view will, but the IVAS is okay.
Yes, that's right, madam. Check.
Excellent result, I think. It is very excellent result. And also this flow also maintaining, though it is timid 2 in the diagonal 1. But I think it will improve in the time.
Besides this, the Professor Azam told that how much myocardium is supplied by this vessel. If it is less than 10%, if the vessel is less than 2.5 millimeter or at least 2 millimeter, then we can ignore it. Otherwise, we have the different opportunities for gel balloon, what I do regularly. For this case, I did not wish to do.
No, you are, sir, absolutely right, sir, regarding diagonal 1. It is also not a 10 millimeter disease diameter.
Another thing that during the final scene, there is a good step up in the proximal zone and good step down in the distal zone in the stand. It indicates the stand apposition is very good.
Thank you.
Now, Professor Mir has highlighted few things, which is that the operator's decision what to do, what to tackle, what not to tackle. He has highlighted that, and then after that, what he has done absolutely nicely and rightly and in the positive direction. He knows what he is doing and he has demonstrated it, and all of us has participated very nicely to come to the goal, and at the end of the result is very good and his decision was right. So I think probably if it was not a live case, he would have done the right at the same time, but because there is some more cases, he's leaving it. So I congratulate the whole team and whole panels and all chairpersons for being with him and with all of us. Thank you very much.
Thank you, madam. Thank you, chairperson. Thank you, other panel of experts for explaining this nice case, which is done by Professor Mir Jamal, who is the course director of BRIC. So thank you. We expect the good wish, best wishes of the BRIC virtual conference. Thank you.
Thank you all. We are going to the next session. I must thank my teacher, Professor Sufia Rahman is here. I am grateful that he is seeing our work, and we are grateful to her as well as our senior cardiologist, senior interventionalist, Professor Malik, and my institute professors, Professor Mamnur Rashid Cesar, Professor Amal Kumar Chowdhury, Professor Azam, and other Professor Khandaker, Shaheed Hossain, and other panelists. I must have to once again thank you for giving us courage to do the case. Thank you. And one thing I like to add, that this is in the distal radial approach, and my regular practice is distal radial approach. After coming the distal radial approach, I tell to my younger colleagues that distal radial is radial, radial is femoral, meaning that after doing distal radial approach, that is the 0.8%, 80% of the radial artery, and doing that distal radial approach, whenever I go to radial, then I feel it is femoral. Thank you. Thank you.
Thank you.